Okay, good morning and welcome. My name's Mary Leonard. I'm chair of the department. It's my great pleasure to welcome you to Pediatric Grand Rounds. So let's just look ahead a little bit at the wonderful schedule. First, of course, to make sure everybody knows about the text codes and the QR codes for CME and American Board MOC Part 2 credit. And then I want to call your attention to the incredible schedule we have in the coming week. So in honor of National Disability Employment Awareness Month, we're going to hear about Ivory Tower to implementation, community engagement in intellectual and developmental disabilities initiatives. And then the following week, we are so proud and so happy that Congresswoman Kim Schreier is coming home. She was one of our own. She did her residency here. She is the only pediatrician in Congress, and she has been doing such important work advancing such initiatives such as Medicaid equity as relates to pediatric care. And she is coming to give pediatric grand rounds and working with Sherry Sager, our government relations person. There's a whole series of events surrounding her visit. So really encourage everyone to come out, make a very strong showing for Congresswoman Schreier, who's just been such an extraordinary advocate for all of us. All right, and then our Stanford University land acknowledgement. We recognize that Stanford sits on the ancestral land of the Muwekma tribe. This land was and continues to be of great importance to the Ohlone people, and we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native people. Next slide. This is a very important week for another reason, and that is this is the week of the annual MCHRI Symposium. This is something we've been doing for 7 years now. We try to be quite strategic in how we put this event together. Of course, it is an incredible opportunity to hear from our own, to hear from our trainees, to hear from some of our new faculty. Dr. Russell, I'm looking at you, and from many of our very, very distinguished faculty. But what we do each year is we pick a theme, and we do it intentionally as in terms of how can we advance that theme on the Stanford campus. So this year, the theme is climate-induced change in maternal and child health. We have a wonderful series, of keynote speakers. But the other thing that's going to happen is we're going to have meetings with these speakers and with Dean Minor, with folks from the Sustainability School, from Ruth O'Hare, the Senior Associate Dean, from other climate health experts on campus. So we use the MCHRI Symposium as an opportunity to really sort of accelerate work in a specific domain here on our campus. So last year, you may recall, it was around community engaged and community empowered research, and we had speakers from Picori and Robert Wood Johnson. So this is really a very important event in terms of our strategy, our vision, and our mission for MCHRI. There's also lots of other exciting things to learn about. I hope some of you who are interested in using big data to do clinical research and health services research that you know about PedsNet. We're going to hear from some of our rising scientists, and then omics and maternal and child health. So it looks shaping up to be a really, really fun and interesting day, and hope everyone will make their way over to Berg Hall on Thursday. Next slide. All right, so I have had the honor on many occasions to stand up and introduce Bonnie, whether she's getting the Howland Award or the MCHRI Visionary Leader Award. It always takes me about 15 minutes, so I'm not going to do that today, Bonnie. She has squeezed this presentation in between her role as the faculty co-chair of the search committee for the president of the university, having just returned from the induction ceremony to the National Academy of Medicine, which I think is just a typical week in your life, Bonnie. So, and you just recently was co-chaired the Red Book Committee, and so we're always so fortunate that Bonnie comes and gives us an update. And then I want to thank in advance Roshni Matthew, who's our co-director of infection prevention and control for the Children's Hospital, who will be moderating the Q&A at the end. So just to make sure our Zoom folks know to submit their questions, and we'll make sure to address those as well. All right, welcome, Bonnie.
Good morning, everybody, and thank you, Mary, for that introduction. This is the first time this year I'm giving grand rounds in the CAM building in person. So it's really nice for those of you who are here to be here in real life. So thanks for coming in. So we have a lot to talk about today. I'm going to try to keep to my watch so I can have some time to answer questions, because there's a lot going on in the world of RSV right now, and a lot of exciting things, but also a lot of operational and logistical challenges. So these are my disclosures, and just notably, I have been working for the first time with an industry-sponsored study since the pandemic with Pfizer around the maternal RSV vaccine and the pediatric COVID-19 vaccines and others, as you see there. So what the learning objectives here, again, you have listed. I really want all of you to understand as much as possible the different strategies around RSV prevention. We're getting a lot of feedback. I've been around the country right now talking to different AAP chapters about what to do around RSV. And I want to make sure that in your own practices, you can identify local resources and engage with chapters as you can, because people are asking a lot of questions right now. So the overall arching strategy for RSV prevention is really to recognize that RSV is a major cause of lower respiratory illness. We as pediatricians know that, but I don't think it's been very clear what the impact of RSV has been on older adults, and especially adults with chronic medical conditions. Now, I'm not giving medicine grand rounds. We're not going to talk about adults right now, and there is an indication, but I just want to mention that because they're having a particularly hard time wrapping their heads around, should we be giving RSV vaccine to people 60 and older? But so that's a separate topic. It is a recommended. RSV vaccine and immunoprophylaxis candidates have been worked on for decades now. We have some really outstanding candidates and some that have been approved now. And our target populations include now infants and young children, pregnant women, and as I said, older adults. So let's go through the epidemiology so that we can remind ourselves why this disease is so important in children. And by the way, I want to thank Hayden Schwank and Lauren Kushner for lending me some of their slides that they've been using at the hospital to really help everyone understand how this is going to be administered. So some of these are their slides that they put together as well. So RSV is one of the most common infections of early childhood. It is the most important cause of hospitalization in kids under 5 and under 2 in the US. And what's really not well known is that about 20 to 30% of kids who have RSV will develop lower respiratory tract disease. And there are risk factors for severe disease, including prematurity, chronic lung disease, and certain forms of congenital heart disease. And I'll show you in a bit the hospitalization rates, which really target kids under a year of age. And you can see there the overall numbers are over 500,000 total RSV, lower respiratory tract infections every year, about almost 500,000 office clinic visits, 150,000 emergency department visits, and almost 100,000 hospitalizations. So quite a high impact in our world here in the US. And it's estimated that about 150,000 children a year under the age of 5 die from RSV all around the world, most of them undiagnosed. And again, 2/3 of children who are infected, 2/3 of kids under a year will be infected, and almost 100% of kids under 2 in the US will be infected by RSV, with premature infants having 3 times higher hospitalization rates than term infants, also higher risks of mechanical ventilation, et cetera. And 2 to 3% of all infants, as I mentioned, highest cause of hospitalization in kids, but very high rates of hospitalization in children. This is our usual CDC type pyramid where we look at the burden of disease, and the tip of the iceberg, of course, is the deaths. Fortunately, in the US, there are not a lot of deaths, but there are many hospitalizations and over 1.5 million outpatient visits. So clearly a big burden of disease in the US and elsewhere. Now, regarding seasonality, we all know, I think we as pediatricians know this, and it was really kind of interesting to watch the media try to understand what this respiratory virus was that was affecting everybody last year. They couldn't say they couldn't say respiratory syncytial for sure, but you can see here when you look back from 2011 to 2020 how predictable the season can be, and we all know that, but you see that there's a little bit of a splay. There's some variability, so we can't ever really pin down the exact date, and that becomes important when we start to talk about when and how we do prevention, because we don't really know exactly when the season might start, but it generally starts around December, around October, sometimes earlier. We know that in this late August, early September, we were starting to see disease in the southern part of the US. And if you look at geographic differences in the US, you can see that overall, if you look at the Northeast, Midwest, South, and West regions, the variability is a little more pronounced. But overall, we see that we do have it's basically in the US a winter virus. Now, outside the US, it turns out that it can, especially in tropical climates, it can be year round, which makes it even more difficult to identify when to intervene, since it's really a year round disease. You can see here, when you look at the dashed line, that's the overall average of cases between October and April. And you can see different regions there laid out of the US. And you can see that there's a variability, with the South usually being the first area to have disease. But we also know that there's a little bit of unpredictability this year, although I would say it's fairly predictable. But as you know, during the pandemic, during 2020, 2021, there in the blue line, you saw that we had no winter disease, but then in the fall, spring and fall, the summer and fall of 2021, we had a weird what we called an interseasonal peak that went on through 2021, 2022. So we think this will be a normal year, normal meaning we'll have a respiratory winter season, but that was a very strange year. And it was also a horrendous year for all of us. As you all know, at one point we had probably 90 kids on ventilators here at Packard. Not all of them RSV, but quite a number of them were. So it was a really bad year. And you can see, when you look overall in the US at two different surveys of hospitalizations, you see that children under a year of age are the most likely to be hospitalized. Those are the bars are different years of surveillance, but you see they mirror each other pretty well. The highest risk for hospitalization, definitely under a year, but especially those under 6 months of age. And in emergency department studies, they're referenced here at the bottom. Again, the highest risk for emergency department and outpatient pediatric clinic visits are in the under 1 year age group, and especially for the emergency department, the 0 to 5 month age group. And then finally, if you tease it out even further by month, you can see that the highest risk for hospitalization in different years really has been in the under 3 month old. So really very young. And this is a problem if we're talking about an intervention, because you can't really vaccinate babies to get coverage in that first 0 to 3 months of age. It's very hard to do that. So other mechanisms have had to be thought of, and I think that'll really lead us into our prevention strategies. So in conclusion for this section, pre-pandemic seasonality is well defined. When we're trying to talk about strategies, we know what the season generally looks like. It's a very common cause of hospitalization. We know risk factors include prematurity and chronic lung disease. And the currently licensed product, which is palivizumab, I'll mention it briefly, only targets about 2 to 5% of kids in the US. So we needed other candidates. So let's talk about those candidates and what they look like. So I'm going to go over a little bit of virology, but just so that you can understand how fascinating the studies of this virus are and how those led to really improved preventive strategies. So you see here the RSV genome. It's 15,000 base pair genome. And there are a number of viral proteins. It's important to note that RSV has 2 strains, A and B. They can co-circulate. There's no cross protection. And they actually surprisingly don't really mutate very much, which means that we continue to get reinfected over and over again without really much variability in the strain. So we know that we have incomplete or at least short-lived immunity in all age groups. But I'm going to point out the protein. There's an F and a G protein that is coded for there in the red, right in the middle of the genome. And those are really the key areas. So if you see here this picture of the virus itself, you can see that there's I actually don't know how to work. Does this, oh yeah, it does. Okay. So this is the G protein here, the little yellow one. It's like it just sticks out. And this is the Y-shaped is the F protein. And those are really the really important targets of neutralization, because those are involved in viral attachment and RNA entry into the cell and cell replication. So those have been shown to be the most important targets for neutralization, for prevention of disease, but also especially in particular, the F protein is important. And so if we know this, why haven't we been able to develop an effective strategy, either a vaccine or a great monoclone? And this is the reason we didn't really, up until about 10 years ago, we really weren't using the right F protein. So as you saw, the F protein looks like a Y there on that little picture. This is what it really kind of looks like. And 2D estimate of a 3D protein. And you can see there on the left, you have the pre-fusion version, and those are different neutralization epitopes on the surface of that protein. And that is the pre-fusion protein. And those are the neutralizing epitopes that are in place before the virus has fused to the human epithelial cell. What happens after fusion is that it really convolutes itself and turns into a very elongated form there on the right. And you can see what's really important there is that the neutralizing potency, the most neutralizing effective epitopes are the red and the yellow epitopes, and they essentially involute into that post-fusion version, so you can't really see them. And it turns out we've been using the post-fusion version of the protein to make all our viral candidates and targeting the monoclones to those areas, which really aren't very high level efficacy for neutralization. So that's been the real molecular issue here. And it was a really surprising finding. And the reason it was so hard to identify is that the pre-fusion protein is incredibly unstable. And so identifying it was difficult to do. And then identifying it in a way that it could be isolated in a vaccine candidate so that it would be stable was also the second problem. So those have been the issues that have been dealt with over the last several years. But that has been why we've made so much progress more recently, even though we've been looking for these vaccines for a while. Sorry, went the wrong way. So in summary here, the F and G proteins, proteins are really important targets of neutralizing antibody, with the most potent antibodies being directed against the F. Trial vaccine products have F or a combination of other antigens, and immunoprophylaxis, in particular monoclonal antibodies, are directed against F. And there is some heterogeneity in RSV F protein, but mostly you can see that the most important targets are there in those site-directed areas that I pointed out. So when we look at vaccine products, there are a number of them. I'll show you a list in a bit, but they fall into a number of categories. The first is live attenuated or chimeric vaccines, protein-based vaccines, nucleic acid vaccines, recombinant vectors, and then finally monoclonal antibodies, which we have been using for quite some time in the form of palivizumab. And you can see here from PATH, the Gates or affiliate slide that you can actually just Google PATH RSV vaccines, and you can come up with this table, and it shows you what's most up to date. This shows you phase 1, phase 2, phase 3 trials, and there's a number of candidates out there looking at from different companies. But you see that this most recently just changed over the summer and early fall. You can see that we have 2 vaccine candidates, one from GlaxoSmithKline and the other from Pfizer. But the Pfizer vaccine is now approved for use in adults, so 60 and older, as well as pregnant women. And I'll talk about that in a bit. And then at the bottom, you see that we have immunoprophylactics, so the monoclonal antibodies, including nirsevimab and palivizumab. So we all have used, I think most of us are familiar with palivizumab. It's a humanized monoclonal directed against the F glycoprotein, and it has a short half-life. So one of the problems with it, the neutralization capacity is not great. It's about 50% efficacious in preventing disease, and it's also mostly effective in children in extremely more premature babies, especially those with lung disease, and in infants with congenital heart disease. And it also has a short half-life, so we have to give up to 5 doses every season. And the AAP is very strict still about recommending its use in children under 29 weeks gestation with underlying conditions listed there. But as I mentioned, only 2 to 5% of kids in the US are actually getting this treatment. That leaves all the other kids out there susceptible to RSV. So what's nirsevimab? Well, nirsevimab is another monoclonal antibody, nearly identical structure and mechanism of action. It has 2 major differences, and that is it has enhanced neutralizing activity compared to palivizumab, so 50 times increase in activity compared to palivizumab. And it has a modified FC region to promote extension of the half-life. So the bottom end of the antibody actually prolongs the half-life almost by 3-fold. So it can actually be given as a 1-dose formulation instead of the 5 doses up to 5 doses that we give now. And it actually is as safe as palivizumab has been in terms of interactions. Let's talk about trials in infants. See how I'm doing with time? I'm doing okay. I can slow down a bit. Sorry. but I wanted to leave time for questions. So there were actually 3 different categories of children that were studied with the monoclonal antibody trials. The first, the order was, they were kind of done and not exactly in sequence, but the 3 groups were children, infants greater than or equal to 35 weeks gestational age, who were otherwise not eligible to receive palivizumab. The other group was infants 29 to 35 weeks gestational age. And then the final group was preterm infants less than 35 weeks gestational age, who also had chronic lung disease or chronic heart disease. So the total number of kids that were studied was just about 6,000 children overall in these different groups. And of course, the first consideration was safety. There was also extensive PK studies and efficacy trials as well. And I'll just skip to the cut to the chase here. The bottom line is that when you look at the overall efficacy of this monoclonal, you can see that compared to placebo, there was between 76 and 78% efficacy in the reduction of either RSV, lower respiratory tract infection with hospitalization, or severe disease. So quite efficacious in all of those different groups. And I'm gonna break it down by each of the study groups that I mentioned earlier. So if you look at safety, again, very few to no safety signals, because we're used to giving monoclonals and we understand the risks there, but there were very uncommon rashes, injection site reactions, and also fevers. So again, very uncommon. Now, if you look back at the preterm infants, so they were less than 12 months of age and they were between 29 and 34 weeks gestation, you can see that about 1,500 children were enrolled in these studies, and it was a single dose, 50 milligram IM dose compared to placebo. And these children were followed out through a year of age. And then there was a second study, which I'll talk about, that followed some kids out through their second RSV season. And you see here that the efficacy of any RSV, lower respiratory tract infection that required a medically attended visit was 70% efficacious, with 78% efficacy reduction in hospitalization. So this is very important in the preterms, again, the children between 29 and 34 weeks. So this is a group that is not usually eligible for palivizumab. That was a real key point there too. If you look at the data for term and late preterm babies, so those 34 weeks and I think between 34 and 37 weeks. Oh no, actually some of them were at randomization. 14% were between 35 and 37 weeks, and 86% were more than 37 weeks gestation. So it was a combination of term and late preterm. Very similar study design. This was 3,000 babies. Again, they were given nirsevimab between a 50 and 100 milligram dose versus placebo, and some of the children were then followed as well through a second RSV season, and I'll show you that data in a bit. So when you look at those babies, the efficacy was very similar, 75% reduction in incidence of medically attended RSV, lower respiratory tract disease, compared to placebo, with a 60% efficacy in reduction of hospitalizations for those children. So again, quite efficacious. And then finally, when you look at this particular study, this was a very small subset of children, about 310 children with congenital heart disease or chronic lung disease. They were followed not only through that first season, but also through a second season, I think trying to understand whether there would be longer term protection from this neutralizing antibody. And you see there that the numbers were very small. The safety was still maintained, but and 98 to 100% of those babies achieved nirsevimab exposures that were predicted to be at the level that would be predicted to be efficacious. But there were no RSV, lower respiratory tract infections through day 151. And the second season, I didn't show the data here, but there was really no big difference between the two groups, the RSV, the placebo and the vaccine group in the second season. So there are a lot of questions about duration of protection. I'll show you some neutralizing antibody data in a bit, but basically the primary and second endpoints of these trials were all through 150 days Efficacy didn't decline over the period, over that basically 5 to 6 month period. But there are some data from South Africa that suggests that there may be efficacy beyond 150 days. And there are neutralizing, if you just look at neutralizing antibody titers, they do seem to be higher, still continue to be identified in high numbers through almost a year out. So there's a potential hint that there may be protection through a year, but the data are not very robust. So it's really not being strongly considered that this will be protective through a second RSV season. So when you look at cost effectiveness, I think this is a really important piece of information as well, in addition to safety and efficacy. When you look at the number of infants needed to immunize with nirsevimab to prevent one of these health outcomes, you can see that the numbers are quite important. So you would only need to immunize or provide nirsevimab to 17 babies to prevent one outpatient visit, 48 to prevent one ED visit, and 128 to prevent an inpatient visit. Now, obviously, you're going to need number needed to immunize would be much higher for ICUs, but still the numbers are really very striking and important, and think achievable in terms of the healthcare costs and logistics, and plus the reduction of burden of disease. If you look at the cost per health event averted, it's also a pretty substantial amount. So you can it's well within normal cost effectiveness for a number of other diseases that we think about in children and adults. So obviously the highest cost would be to prevent an ICU admission, but even for an inpatient admission, it would be $20,000 per hospitalization averted. So pretty reasonable cost effectiveness. So what happened with nirsevimab? There was a lot going on, obviously, with the maternal vaccine and nirsevimab all getting reviewed and approved around the same time. So the FDA approved nirsevimab in July of this year for neonates and infants born during and entering their first RSV season, then also for children up to 24 months of age who remained vulnerable and had selected conditions that would put them at risk for higher risk for disease in their second season. And I'll go over those in a bit. And then the ACIP provided approval as well. And this is an unusual move by the ACIP because they generally only really provide recommendations for vaccines. And that was a big issue that I know we were talking about it when I was still with the Red Book Committee, trying to understand from CDC and FDA how they were going to market this or actually label it. It's technically not a vaccine, but they do call it an immunization. And the reasons for that are important because if you have a vaccine or an immunization, it is covered under VFC or vaccines for children. And this nirsevimab and palivizumab as well fall into this odd category. So for example, for palivizumab, ACIP never got involved with recommending or reviewing evidence to recommendation or cost effectiveness or national recommendations, or more importantly, administration infrastructure and payments. They didn't get involved because that wasn't their mandate, given that it wasn't a vaccine. I think a lot of us were able to work together to convince ACIP and CDC to really take this on as a potential major impact on burden of disease in kids, and to really try to label as much as possible under the vaccine rubric. So there is a bit of it's really not it's not obviously a true vaccine, but it does have some recommendations to be covered, and we'll talk a little bit about that in a bit. So the ACIP then approved this as one dose for all infants, so every baby aged less than 8 months, born during or entering their first RSV season, and one dose for children 8 to 19 months of age who are at increased risk for severe disease and entering their second season. So I'll go over that in a bit. This is really busy, and thanks to Lauren and Hayden for finding this slide. I have to look at it a long time, so I'm not going to go through it. But basically, this is something that you could probably put up. If I were a general pediatrician, I'd put it up in my office and just check where the baby sits. So basically, the recommendation is to give the vaccine between October and March. For babies who are born between October and March, they should get the vaccine within a week of birth. because they're going to be at risk for entering that RSV season. But if the babies are born off season, then they can wait and get their first dose right around October to March. So the bottom line is, if you're not born between October and March, you don't have to get that first dose then, but you should get it before, as soon as possible when the season starts, meaning October to March. And if you are born during the season, you should get the vaccine within a week of birth. So this is just a way of calculating. If you're born in April, basically everybody should be getting vaccine back there in October. So what about the second season? Well, much like, given that the data we have, we were really trying to get this product approved and used for this RSV season. The recommendation was based on data that were available at the time. We're hoping that there might be more data available next year. We'll just have to see how that works out. But for the second season, there were children who were deemed to be at risk for severe disease, and those include children with chronic lung disease of prematurity who required medical support at any time during the 6 months before the start of the second season, children with severe immunocompromise, those with cystic fibrosis who have a number of other medical indications there, and American Indian or Alaska Native children. That's an important category based on demographic data that suggests they are at higher risk for RSV disease. So these are for children, remember, 8 to 19 months, who are going into their second RSV season. So it won't be every child, but there will be a subgroup who will need, what should be recommended to get this 1 second dose of nirsevimab in the second season. So providers should aim for administration, again, as I mentioned, the first week of life for those born shortly before or during the season. It can occur during the hospitalization or in the outpatient setting. And those who have prolonged hospitalizations because of prematurity or other causes should receive nirsevimab shortly before or promptly after discharge. It may be given to age-eligible infants and children who have not yet received a dose at any time during the season. And we're aiming for October through March, but much like we did with and I think you should just follow the AAP guidance that they put out on a regular basis. If the season should start early or end late, there will probably be guidance from the American Academy of Pediatrics. I wouldn't wait for the CDC to make that recommendation. It will probably come from AAP like it did when we had that interseasonal RSV season back in 2020, 2021. There's a lot of other considerations. I won't go through these now, but just to say that there's a pretty nice reference that in the CDC website. You can just Google CDC RSV and you'll get the whole document. You can also go to the American Academy of Pediatrics. There's a nice document there that outlines all of the information that you need for nirsevimab administration for additional considerations. I will say that if a child is eligible for palivizumab and has gotten that, and they can get nirsevimab, they don't need any more palivizumab for the season. So they don't need to go through the 5 months of palivizumab and nirsevimab. Once they get nirsevimab, you can stop, because again, it has a very long half-life. So how is it given? Similar to other vaccines, I think we're all familiar with giving palivizumab. It comes in 50 and 100 milligram doses, and 50 milligrams for children under less than 5 kilos, and 100 milligrams for those 5 kilos and over, and 200 milligrams for kids who are entering their second RSV season. So this is, I think, where we're a little confused. I think based on ACIP approval, as I mentioned, it was also approved for vaccines for children. I think this is probably a first in terms of getting approval for something that's not a vaccine. And VFC covers immunizations for children, as you know, who are Medicaid eligible, uninsured or underinsured, or American Indian or Alaskan Native children. And then complex care, and I hope this is still true. Complex care is the only VFC clinic at Packard, is that right? Yeah. And it's expected to cost around $500 in the private sector and $400 in the VFC program. Remember, that's less than the $5,000 that it costs just to buy palivizumab. And from what I understand in the private sector, that I was talking to people from around the country recently, it's actually more expensive that when you add in all the other costs for putting in palivizumab. But that said, it's still not cheap. And so people are worried about buying it and maybe not being offices maybe not being reimbursed this year because insurance is supposed to reimburse, but it can take time. So we're hearing that some insurance providers are not yet reimbursing, and we're not quite sure what's going to happen at the end of this season. We think by next season it will be covered, but that doesn't really help people who have children who need it today. So of course there are a number of challenges. First of all, it's really exciting to have this product. This could be a game changer, but as a first year rollout, there are challenges. So equity of access, people who have insurance or people who can pay out of pocket are obviously going to be more able to get it. People who live in areas where hospitals, say big providers who will provide the nirsevimab during hospitalization will tend to be in urban academic medical centers, city areas, as opposed to small rural areas that might not be able to afford to spring for the cost of nirsevimab. And so that may be an inequity this particular year. We're hoping that this won't happen going forward in the next years. And it's not in the bundled payment model for newborn care, although I think there is a code now for administration of nirsevimab, but it's not a bundle, so you may not get guaranteed payment there. VFC considerations are important, and we have to make sure that it's captured in our immunization information system, our care system here. And there's the code there that we are using. And of course, we want to make sure people report adverse report events. And then, which I'll talk about next, the next piece I want to mention is, what about the maternal RSV vaccine and how do we decide which to give, and should we give both or none? What's the story there? So we'll talk about maternal RSV vaccine next. So this is a game changer. I think it's safe, it's highly effective, it's based on really remarkable discoveries around the structure of the fusion protein. And I think, this is going to make a big difference, but this is going to be a tough transition year. And I think most pediatricians, it's funny talking to people over the summer and now until even last week, people at first were saying, oh, I can't do it this year. And when I took a poll of some pediatricians in Florida last week, everybody was raising their hand. They said, yeah, some of us are just going to go ahead and eat the cost. People who work for bigger providers, bigger clinics, were actually getting it through their hospitals. So it's a combination of hospital-based, clinic-based, but clearly rural areas or single providers are not going to be able to have access this year, I think. And again, this is from Hayden and Lauren, just to talk about the guiding principles that we always use with all of our care, but especially with something that rolls out that's new, that affects just about every child in this country. And these are the areas that we like to consider: equity, alignment, cost, capacity, and evidence. So here at Packard, nirsevimab will replace palivizumab, although I'm just hearing last night, I was like 2 in the morning, I was reading my AAP updates. I don't know who writes them at that hour, but they do. They said, well, it turns out that you can't order it now because we had an overwhelming response. And that was interesting to hear, because when I was traveling around, even just within the last 2 months, like I said, back in July, August, people said, oh, I'm not going to do it. And then last week, people were saying, yeah, we're all already ordering. And so it turns out now we have a back order because there was an overwhelming response. There's a lot of nirsevimab being ordered. And as of last night or early this morning, AAP is recommending that people just put their names, hold off on ordering and check back with the AAP website to see when the drug is available. It's not only not available from the public sector, it's not available from Sanofi either. So they're trying to get their production up in line. I don't know exactly what the time frame is, but we'll find out. And as soon as AAP finds out, we'll all find out as well. This is just to show you, and thank you to Rajni for her work around tracking viral diseases in the hospital, but this is just to show that in the pink is RSV. So that was just a few weeks ago. We're not seeing a lot of RSV yet, but we are hoping to start giving this in the hospital from November 1st to March 31st. And we're almost there, so probably we won't start sooner. And inpatient nirsevimab will be offered within 48 to 72 hours of discharge for infants admitted less than 8 months of age who have not yet received nirsevimab. Those 8 to 19 months of age who have not yet received it during their second RSV season and are at increase of our severe disease as we outlined previously. And there's not currently a plan for administration in the SSU post-discharge. So the plan is to embed nirsevimab within existing order sets as well as separate orderable administration. The outpatient administration is preferred whenever possible, and patients should not be admitted solely for the purpose of administration. And I think this is as up to date as I got from Hayden. We've received confirmation of interest from the Complex Care Clinic, Pulmonary Clinic, and the Bass Center for administration. And it was projected to be widely available until last night. So now I think it is widely available, but it got all sucked up by all the people excited to use it. So you should confirm that your patient has not already received nirsevimab before ordering it, and then of course use the California Immunization Registry. Now I want to talk about the maternal vaccine because this is really important as well, and I think a lot of us are going to struggle with how to do this together. It's thrilling to see that we have two amazing opportunities to vaccinate babies and prevent RSV, but it's also going to be, again, a little confusing. So as you probably know, in August, the FDA approved the maternal RSV vaccine as the first vaccine for pregnant individuals to prevent RSV in infants. And then in September, a month later, the CDC recommended the new vaccine as well. So there's been a little bit of controversy around this, but it's actually, I'm going to go over the data and show you that, how exciting this is, but also the operational challenges. So this is the bivalent RSV prefusion F vaccine. It's again targets RSV serotype A and B, 120 microgram single dose injection. And it is indicated for the prevention of lower respiratory tract disease and severe respiratory tract disease caused by RSV for infants from birth through 6 months of age by active immunization of pregnant individuals. So again, we talked about the prefusion protein there on the left, and you can see that the red area is the target for nirsevimab, the yellow is the target for palivizumab, and then you can see how they are really involuted here in the elongated form. So really important technical achievement there. The RSV, this is a study, and I have to call out Dr. Natalie Aziz from OBGYN because she and I co-led the studies in the pregnant women. She really did 99.9% of all this work in getting the pregnant people in and vaccinating them and tracking them and following them up. We had several false starts and stutter steps because of the pandemic. So we actually approached in 2018. We couldn't get our act together at that point to try to get it organized because they were moving pretty quickly. But then the trials were started in 2019, and then the pandemic happened, and for a lot of logistical reasons, they couldn't continue. So they started up again in 2020. And then we enrolled, and there was no RSV season that year. So we had 0 cases in any arm. And so we had, either infinity efficacy or 0% efficacy, however you wanted to calculate it. And so then we started again. So this was like our 3rd time around. And we not only here at Stanford, but elsewhere enrolled in these studies. But it really is a pretty well-studied vaccine. You can see all the phase 1, 2, and 3 trials in very different groups, first in human back in 2018, pregnant women in 2019, non-pregnant women, again, 2019, and then pregnant women, again, the efficacy, the pivotal study that really started in 2020 and was published this last year. And you can see when you look at neutralizing antibody titers at delivery among pregnant women, you can see that compared to placebo at delivery and then 6 months postpartum, you can see that compared to placebo, there's a pretty high titer of neutralizing antibody to the prefusion protein. In the blue bars are the vaccinated women compared to the placebo. And you can also see that transplacental transfer of antibody it's an active transport, and you can see that the level there exceeds the maternal level in all patients overall. but they were split up between Northern and Southern Hemisphere and also by gestational age. And you can see in all gestational ages studied, there was active transport of antibody across all the way from 24 weeks gestation through 36 weeks. So evidence that you had good antibody levels in not only in the mothers, but in the infants. And this slide, the red dotted line demonstrates what the palivizumab antibody levels look like across the 6-month period if you're giving the 5 doses according to schedule. And you see in the placebo group in the gray, those antibody titers just drop over time naturally. But you see that in the vaccinated women, this is in the babies. The babies of vaccinated women actually have titers that exceed or at least meet palivizumab levels through 6 months. So at least based on based on antibody levels, you're going to have some protection there. And so you see that the trial that was undertaken was almost 7,500 pregnant people in 18 countries, the majority coming from the U.S. These were pregnant people between less than 49 years of age, between 24 and 36 weeks gestation. Essentially the efficacy, I'll tell you the data. The efficacy if you looked at from 1 month through 6 months, the efficacy went from 80% to basically 70% efficacy. So even at 6 months, there was about 60 to 65% efficacy, I think. Did it work? No. So there was 80% efficacy at 1 month, but all the way going out to 6 months, it was about 60% efficacy. So highly efficacious in getting all the way through 6 months. And there were data going out through the second year. And what we found was that there was about 50% protection through the second year, but it would have very wide confidence intervals. So really was not thought to be protective in the second year. So the bottom line, and the safety and efficacy were the really important piece. So the safety and efficacy were the usual things you would expect from vaccination. So pain at the injection site, some fatigue, malaise, etc. Now remember, these are pregnant people. That's why you have placebo groups. The placebo groups were just as likely to have all the symptoms of nausea, vomiting, except for one thing, it was myalgias that were more common in the vaccine recipients. The one signal that was a concern, really hearkening back to the days of RotaShield vaccine. Oh, there we go. Was, so I'll just really, I don't want to take too much of time here. Thank you so much. Sorry about that. So just to show you that the demographics were very broad. So 67%, 65% white, but 20% African American and 12% Asian and 30% Hispanic or Latino. So quite a wide demographic range. The phase 3 study objectives, again, were safety and efficacy. You see that erythema, induration, and pain were the most common side effects. And women had, vaccine recipients were a little bit more likely to have muscle malaise compared to the placebo, but otherwise was the same. This is the big signal, and it looks tiny on this slide. I don't know how to make it bigger. I could have, but this was from the CDC. So the total premature babies that were born premature were 5.7% in the vaccine arm compared to 4.7% in the placebo arm. Now that wasn't statistically significant, and most of those happened 30 days after receipt of the vaccine. But because there was another product from another company that had been pulled from studies because there was concern about preterm births in that study, and we never saw the published data on that, and these vaccines were very similar, the FDA was quite concerned about this signal. And so when the vote was taken in August by FDA to approve, by the advisory committee to advise the FDA, 4 of the 14 members of the committee voted no because they were concerned about the preterm issue here. But again, the FDA has decided to go forward. But what they did is they actually, I'll just skip through this. They actually voted to approve the vaccine at 32 to 36 weeks gestation. So they actually chose to limit the exposure of pregnant women to really skirt this idea that there might be preterm births, especially in those younger, in those earlier gestation age pregnancies. So the overall efficacy, as I mentioned, was between 80% efficacy 90 days after birth, all the way to 70% efficacy at 6 months, which is really, again, pretty remarkable and very similar to what we saw with nirsevimab. Second season, again, in the 50 percentile range, but really broad confidence interval. So not sure that there's going to be protection in that second season. And let me skip hospitalizations, but basically what I want to focus on now is the benefits and the risks, if you will, of both of these products. So the benefits of the maternal RSV vaccine is it provides protection immediately after birth, may be more resistant to virus mutation. That's a really interesting argument, which I don't really follow, but the idea that a vaccine provides polyclonal protection rather than monoclonal protection, I guess that is a scientific argument, but it's hard to prove that at this point, but it is a possibility. And then you avoid an injection of the baby. The risks are protection is reduced if there's fewer antibodies produced or are transferred from mother to baby. That is if the mother's immunocompromised or the infant is born shortly after immunization. And then secondly, there's a potential risk of preterm birth, which I think they're trying to limit with the indication for 32 to 36 weeks. Now for nirsevimab, the benefits, the studies of antibody levels suggest that protection might wane more slowly. And there is some data to suggest that it does wane a little more slowly. But again, you're getting such robust antibody levels. I would say that they're essentially equivalent. You can provide antibodies directly if the infant receives less antibodies from the mom, and no risk of adverse pregnancy outcomes, which people were concerned about. But again, the risk, as you're seeing today, is potential limited availability this season, and then the payment issues, et cetera. So I don't think there's really, you can weigh one over the other. I think it's really a matter of choice. And I think it's always great to have choice for a product so that people feel comfortable with making their decision. It's a really interesting thing that the survey that was done among a number of people was 500 people, so not a big survey, but still 28% only wanted the maternal vaccine, 25% only wanted the nirsevimab, 38% wanted both, 8% wanted none, and 1% wanted other. Now, I'm surprised that 8% wanted none. I think this is a skewed population. I think a lot of people probably aren't going to want anything in the first season, but we're hoping that there is interest. And I was hearing from different practices that there's a lot of people really interested, and it's also in the way that it's presented by the provider. Now, if you give both, the cost effectiveness is really not good. So because they're both so efficacious, they don't really add much. So it's over $500,000 basically cost effectiveness compared to what I just showed you for nirsevimab alone. If you give both, because you need to, you're providing an incremental improvement in if you give the mother the vaccine and the baby nirsevimab. And so I won't go through the challenges, but some scenarios to consider is administration of nirsevimab when the mother has been vaccinated. So you have to have receipt of the maternal vaccine is confirmed. So if you don't have it confirmed, does that mean the mother wasn't vaccinated or that it just wasn't in the chart? Infant, again, born within 2 weeks of vaccination. Those born premature, because we know that the younger in gestational age the less likely you are to have a high level of antibodies. And then the healthcare provider must recommend maximizing protection because the infant is at high risk of severe disease. So these are different scenarios to consider. And here are some considerations that came from the CDC. They have a nice guidance document. So if a child is less than 8 months of age, if they meet the 3 following criteria, then they should be vaccinated. That is, either the mother didn't receive the RSV vaccine during pregnancy at least 14 days prior to birth, or you don't know the mother's status, number 1. Number 2, the baby, the nirsevimab administration is going to occur between October through March. And number 3, this baby has never received a dose. And if you meet those 3 criteria, then you probably should recommend nirsevimab because that will probably be a minority of babies. And then there's also a scenario for those over 8 to 19 months of age. So I hope I gave you some time for a few questions, and thank you for listening. I think we're really excited about having these two products, but I was talking to the new chair of the Red Book Committee, Sean O'Leary, and he said he came to visit a few months ago, and he said, I have a headache because I'm talking, you know, this nirsevimab is driving me crazy, but it's good to have this kind of a problem. That is, we have two amazing opportunities to prevent RSV disease in kids. Thanks a lot.
Bonnie, thank you. The very great presentation. I appreciate it. Does it make any sense to vaccinate people under 60 if they're in frequent contact with infants?
So that's the whole cocooning idea, right? And we thought about that with Tdap. And by the way, California was the lead in Tdap immunization. It wasn't recommended for that use. And in 2012, we had an outbreak in California, and the California Health Department unilaterally decided, let's just recommend Tdap to pregnant women because we don't have anything else. There's a huge epidemic in California, and we think it's safe. And so based on that, retroactively, the FDA approved it many years later. But the point is that the studies were shown that vaccinating the pregnant women worked really well, but cocooning or even vaccinating around the baby other than the pregnant woman did not work. And studies have subsequently demonstrated that. So based on that, I would say no.
Well, I was wondering about healthcare workers.
Yeah, well, that's a good question. I don't know. We didn't really talk about that. I think, you know, based on what we did with COVID, I think if we do other things and we're careful otherwise, we should be safe. But there aren't any data yet. And we'll see if they do studies in healthcare workers. Some smart ID fellow will do that study.
The data that you presented is super exciting. And it's 70 to 80% is really, I feel like there's clearly maybe a little bit of room that could be improved, like for improvement. And I'm wondering in terms of like future iterations of the vaccine or passive immunotherapies, like what do you think would kind of help bridge that gap in, or like, you know, where the next step in improving efficacy would be? Is it like different protein Fs, like from different strains, or is there another mechanism other than neutralization worth targeting?
Yeah, you know, it's interesting. I don't think 80% is too bad, actually.
It's good.
Yeah, other than the
Take it back.
Yeah, no. I think we're achieving I think I haven't modeled it yet, but I'm suspecting that if you have 80% reduction in a huge cohort, you're going to reduce overall circulation of the virus, and we may start to see it try to taper down over time, much like we did with rotavirus. But I do think that there are a number of companies, as you indicated, that are trying to hone in a little better on those sites, like that site 0 and that site 1, that have very, very potent neutralizing capacity. So I think that's where I would go. If I would just maybe try to look a little more at those particular sites. So that's a great question for the next generation. The other thing I would think about, maybe not necessarily just around RSV, but as we have heard, there are a number of other candidates that are trying to put together a combo vaccine. So you could get a flu, RSV, maybe COVID vaccine all at one time. So those are some other considerations.
Thank you so much for the talk. I was curious about the nirsevimab being labeled as a vaccine, and I was curious if there was precedent for that, and if you've noticed like confusion spreading. I guess I speak from experience at Gardner Clinic last week. Everybody was like, how is this a vaccine? It's a monoclonal antibody. And there was like, I'm just curious if patients have been confused or kind of education around that.
Yeah, so that's a great question. And this is why we've been doing the roadshow and talking to as many chapters as we can, because I think all of us as pediatricians understand the difference, but trying to message that to families. So I did a little podcast last week with healthychildren.org so that when parents go to the Healthy Children website, they can just hear, what is it? And you just say it's a protein. It's that you produce when you give somebody a vaccine, but it's given directly, et cetera. So trying to explain it to families so that when they go on those websites, they can pass that information along. So I think you're right. The key to all of this is education. And really words, again, as everyone says nowadays, words matter. You can call it a vaccine. It's not a vaccine, but it was called an immunization because for administration reasons, right? If it's an immunization, then you can pay for it through VFC. That's a huge deal because over half of US children actually qualify for VFC, sadly, I guess, because that means they're under or uninsured. So it does make a big difference. If that hadn't happened, this would have been a real issue around equity. But thank you for that question.
Thank you so much, Bonnie, as always, for a very comprehensive talk.
Thank you. I want to thank you and Hayden and Lauren and the whole ID team and all of our Packard colleagues as well for helping us ramp this up. Not everybody decided that they were going to get nirsevimab at the hospital level. So we're hoping that it goes well, and we'll see what happens to this season. Hopefully I can't imagine it'll be anything like last season. So really.
I think we'll take one last question.
Thanks, Bonnie. Amazing talk. One comment, we deliver 81% of the Medicaid births in San Mateo County. So I'm so appreciative that we have decided here to give it. It will really help our community partners and help protect our community. So I appreciate that. The second thing, my understanding of where we're kind of headed with thinking about race and ethnicity is not to include it in clinical guidelines. And so to see it as American Indian, Native Alaskan on your chart was a little jarring for me. So wondering how you're thinking about that, since I think are thinking race and ethnicity as a more of a social construct and not a biological construct.
Yeah, that's a great question. And I think the data from RSV disease is just like some of the bacterial pathogens in the Alaskan Native and American Indian populations, that they are higher risk genetically, we think, or they may be predisposed. So I think that is a touchy subject at this point, but I think it was chosen because there were data showing that they had much higher levels of infection, even when you accounted for social and demographic factors. So I think we'll have to understand that better. I don't think we've done a good job of understanding that, but clearly we know that those populations, for example, are higher risk for pneumococcal disease and Hib disease back when we had a lot of that. And so, yeah, I think that's a really important point to bring up, I think, in future discussions about the rollout. And I think we fast-tracked this pretty rapidly because the season was really impending. The approvals happened right in August, September, and we only had a few weeks. But I think this is an important topic to bring up in the future. Thanks for bringing it up.
Thank you all for coming. And we couldn't get to all the questions, obviously, but thank you so much. Thank you, Bonnie.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.